I'm starting with today's session now. So, greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clirnet, serving as the allocated session assistant to ensure a seamless experience. Clirnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for doctors. Clirnet is elected to be chosen as a digital partner for this event organized by National Medicos organization. So today's focus would be physiology clinical cases discussion day one. So for the further contribution, I would like to invite Dr. Ajay sir to take over. Over to you, sir.
Yes, ma'am, thank you. Today, the session will be by Dr. Pernenki Srinivasa, sir, President RG Bharati Andhra Pradesh. I especially thank Dr. Swastika and Ritu from Clirnet team. Sir, can you start?
Okay. Uh, Thank you, Ajay, for taking the pains to organize this meet. And thank you, Swastika, for giving us this wonderful platform to take this class. So, before I start, am I audible, Ajay?
Yes, sir, you're audible, sir.
Okay.
And thank you
So,
for the opportunity, sir, to organize.
okay. So, I will start with a small prayer to Lord Dhanvantari. Namami Dhanvantarim Adidaivam सुरासुरैर्वन्दित पादपद्मं लोके जरारुक् भयमृत्युनाशं दातारमीशं विविधौषधीः. We consider in GSL Lord Dhanvantri as the Lord of Medicine. We have a temple also here. So, next slide. So actually, National Medicos Organization of Andhra Pradesh had approached me uh, asking for some class for physiology students. The National Medicals Organization is a national organization of India who have this motto of Swasthya Seva se Rashtra Seva. That is, the national service is by health service. So they believe in making all the medicos good medicos so that they will be of help to the country. But because I was a little busy for the last few weeks, because of we had a group of students, very eager students from Uzbekistan, I was not able to do it last week. So I have started it from today. This will be for 4 days, and I'm going to cover almost all the cases which are going to come in the examination. Now, next the question will be next slide. Next slide. The question will be why clinical cases? Because from this year, there is a change in the pattern of the question paper for first year MBBS. In both the first paper as well as the second paper, there are going to be 5 clinical case questions. That means one question of which is an essay mark that could be for 10 marks, whereas 4 short notes, that is 5 marks, can be of clinical cases. Or it could be that 5 short cases or 5 cases could be for 5 marks. So 25 marks will be from clinical case minimum. In addition to that, you will be having 5 questions in the MCQ in every paper based on clinical cases. So on the whole, 5 marks in the MCQs and a minimum of 25 marks in the essay question paper will be from clinical cases. So that is 30 marks. Rest of the 20 marks you are going to get from the entire portion. So if you see, we can easily get full marks in clinical cases. That means 5 out of 5 you will be able to get in clinical cases. And if you are able to do this clinical cases question correctly, you will be definitely getting a distinction. So that made me think that once we go through the common clinical cases which have been asked for the past few years, the student will be able to get very good marks. In addition to that, when I was teaching the Uzbekistan students, they also told that this type of learning is really exciting. They were able to understand the subject better if they have objectively have a clinical case. So that is why I thought of taking this. And today is going to be the introduction class of why we have to do the clinical cases and why I have taken all this. From tomorrow, the entire hour will be only on clinical cases. There will not be any discussion other than that. So tomorrow also will be endocrines. We'll be doing all the other endocrines. So today we'll be doing only thyroid, whereas tomorrow we'll be doing the rest of the endocrine cases. Later on, I have divided it into CNS, CVS, blood, because these are the main questions which you will be getting. Okay. Now let us go to the clinical case. Next slide. A 28-year-old woman presents to the outpatient clinic with complaints of fatigue, weight gain, despite a poor appetite. So, weight gain despite a poor appetite means she is not eating properly but is having a weight gain. Cold intolerance and constipation for the past 4 months. Cold intolerance means she is not able to bear cold. She is comfortable if it is warm, but if it is a little cold, she is not able to bear it. Constipation means not able to pass the stool properly for the past 4 months. She also notes swelling in her face and puffiness around her eyes. Swelling in her face and puffiness around her eyes. On examination, her pulse is 56 per minute. That means she is having bradycardia. 56 per minute. Her skin is dry and coarse. Coarse means rough. It is dry and coarse, and there is mild non-pitting edema in her lower limbs. Mild non-pitting. So you have two types of edema, pitting and non-pitting. She's having a mild non-pitting edema in her lower limbs. Her voice is hoarse and the thyroid gland is not visibly enlarged. That means the thyroid gland is not enlarged, but her voice is hoarse. Hoarse means it is deep. Generally, you have a shrill voice for a female patient. Here, her voice is hoarse. Laboratory investigations reveal serum TSH is 12 international units per liter. Normal is zero point 0.4 to 4 international units per liter. Free T4 is low, free T3 is low, anti-TPO antibodies is positive. Anti-TPO antibodies are positive. So I think you have a faint idea about the whole case. A 28-year-old woman, that means she's just in middle ages, presents to the outpatient clinic with a complaint of gaining weight in spite of poor appetite, cold intolerance, and constipation. She of 4 months. She also notes swelling in her face and puffiness around her eyes. Pulse is 56 per minute. Her voice is dry and hoarse. Anyone would like to guess what this case is? You can unmute and then tell the answer and again mute yourself. Very good. Very good. Hypothyroidism. See, actually, in the first year, it is not important for you to diagnose the disease. It is important for you to know what causes the signs and symptoms, what is the function of thyroid hormone, more than what is the diagnosis and treatment. But nowadays, for your examination, they are asking diagnosis also. But if I was examiner, I would not have paid much for the diagnosis. But you are right, it is hypothyroidism. Next slide. The questions which come after the case is explain the negative feedback mechanism involved in regulating thyroid hormone secretion and why TSH is elevated in this patient. I told you that the TSH is elevated. You have to tell why the TSH is elevated. Second question would be describe how decreased thyroid hormones levels affect basal metabolic rate and oxygen consumption in tissues. What happens to the basal metabolic rate if thyroid hormone level is decreased and oxygen consumption in the tissues, whether it is decreased or increased. Next. Next slide. Third question is why does hypothyroidism cause bradycardia despite the patient becoming having edema? See, when a person has edema, what is edema? Edema is the accumulation of fluid in the body. So, whenever a person will be having edema, you should be having tachycardia. But here, the person is having an edema and is having bradycardia. That means the heart rate is less than 60. So, relate your answer to thyroid hormone effect on the cardiac myocytes and adrenergic receptors. Fourth question would be how does hypothyroidism lead to cold intolerance? I told you the patient is not able to bear heat. I mean, is able to bear climate, is not able to bear cold. So, how does hypothyroidism lead to cold intolerance? Mention the role of thyroid hormones in mitochondrial function and uncoupling of the proteins. What changes in protein turnover and glycogen storage occur in hypothyroidism, and how do these contribute to weight gain? So, these are the 5 questions which will be given after the case. You should be able to answer all the 5. Each question will be having either 2 marks or 1 mark or 3 marks. So, these are called structured question answers. So, a case is given, and these 5 questions you should be able to answer. Next. Yeah. So, first is why there is an increase in the TSH. The answer is the hypothalamus secretes thyrotropin releasing hormone, isn't it? The thyrotropin releasing hormone is secreted by the hypothalamus. What does this do? This stimulates the anterior pituitary to release thyroid stimulating. So, once the thyroid stimulating hormone is released, it stimulates the thyroid gland to produce T4 and TSH. So, what is the thing which happens? Whenever there is a requirement for thyroid hormone, the hypothalamus secretes thyrotropin releasing hormone, which stimulates the anterior pituitary to release the thyroid stimulating hormone. This stimulates the thyroid to produce.
Is there any problem?
Yeah, my screen has gone blank. Ah, now it's there.
Yes.
T4 and T3 normally inhibit thyroid releasing hormone and TSH. Once the thyroid hormone comes back to normal, it has a negative feedback on the thyrotropin releasing hormone. In this patient, low T3 and T4 fails to suppress the thyroid stimulating hormone, so the pituitary produces more and more TSH. That's why there is an elevated thyroid stimulating hormone. So, so the first question is because of the hormonal axis negative feedback mechanism, the patient is not having thyroid hormone. See, commonly this is because of one autoimmune disease which is going to cause a decrease in the production of T3 and T4. The cells producing T3 and T4 will be less in number because of the antibody effect, and that is why the T3 and T4 are produced less in spite of having an increased thyroid stimulating hormone. That means the decrease in T3, T4 is going to stimulate the thyrotropin releasing hormone. That is going to stimulate the thyrotropic releasing hormone, stimulating hormone. And though these are high, the gland is not able to produce T3 and T4 because of the less number of cells producing the T3 and T4. And for people who are writing the exam now, the formation of thyroxine is also an important question. How T3 and T4, what are the 5 stages which produce T3 and T4? That is also important. So this is called primary hypothyroidism. Means the hypothyroidism is because of the gland itself. It is not because of anything else. Next. Yeah. Then metabolic effects. Thyroid hormones action is they increase the basal metabolic rate by stimulating sodium potassium ATPase activity and mitochondrial enzyme. This is a very important function of thyroid hormone. So it has an action on every cell in the body. Understand? Because sodium potassium ATPase, it means sodium potassium pump, is present on all the cells in the body. So these pump is activated by thyroid hormone. So whenever there is an excess of thyroid hormone, these pumps are overstimulated. Whenever there is a decrease in the thyroid hormone, these pumps are understimulated. That's why the basal metabolic rate decreases when there is hypothyroidism. Thyroxine increase the consumption in most tissues. So when there is a decrease in thyroxine levels, the oxygen consumption also decreases. In hypothyroidism, it's decreased in BMR, reduced calorigenesis. Calorigenesis means the heat production is less because the sodium potassium pump is not functioning properly. The calorigenesis is not taking place. That's why they are cold intolerant. Lethargy. Lethargy means feeling weak, feeling dull. There will be weight gain because the BMR is low. So here the cause of the weight gain is not increased consumption of food. Here the cause of the weight gain is decreased BMR. When the BMR is decreased, that means the basal metabolic rate is decreased, the amount of energy which is being used up in the body is less. So the patient will be gaining weight. Hope you have understood. Here the weight gain is not because of increased consumption of food, it is because of the decreased BMR. Why there is a decrease in the BMR? Because the sodium potassium ATPase pump is not functioning properly. Next. Next. Next slide. Next we come to the cardiovascular changes. This is also a very important change. The T3 increases the number and sensitivity of the beta 1 adrenergic receptors. See, these beta receptors, alpha receptors, beta receptors are present on the heart and the blood vessels. So, T3 will be increasing the number and sensitivity of the B1 adrenergic receptors in the heart. So, when the thyroid is normal, when the thyroxine is normal, the number of B1 adrenergic receptors will be high. And also, they will be more sensitive. Because they are sensitive, the heart rate will be increasing, the contractility of the heart will be increasing. But when there is a decrease in the thyroid hormone, the number of B1 receptors will be less and the sensitivity also will be less. So this low T3, fewer B1 receptors, reduce sympathetic effect on the heart, and there is bradycardia. I told you here the rate of the heart is 54. So here the heart rate is not decreasing because there is an increase in the parasympathetic. It is decreasing because the sympathetic receptors are not functioning properly. Why are they not functioning properly? Because they are not being sensitive, as there is a less amount of thyroxine. Next, we come to the edema. I told you, when the person is having edema, the heart rate should increase. But here, why is it decreasing? So this type of edema is called mixed edema, because here it is not because of the presence of increased amount of fluid in the tissues. It is because of a deposition of a mucopolysaccharide in the interstitial spaces. See, normally when we talk of edema, we talk of two pressures. One is called the hydrostatic pressure, one is called the oncotic pressure. Whenever there is an increase in the hydrostatic pressure, for example, in heart failure, there will be edema, ascites. Whenever there is a decrease in the oncotic pressure, for example, in a liver failure or in a kidney failure, where the kidney is not able to filter the albumin, the albumin decreases. This causes a decrease in the oncotic pressure, which leads to edema. So there, the edema is because of the fluid accumulation in the tissue spaces. Whereas here, in mixed edema, the fluid is not accumulating. It is mucopolysaccharide deposition in the interstitial spaces. That is why this type of edema is called non-pitting edema. Why is it called non-pitting edema? When you press it, there is a depression. When you leave it, the depression is lost. Whereas if there is fluid, what will happen? When you press the bone, there will be a depression, and that depression is going to stay like that. So in mixed edema, the edema is non-pitting. This is one of the important signs of hypothyroidism. Next. Next. Next slide.
Sir, is the slide change?
No, it's not. Now it has changed.
Yes, sir.
Now we will come to cold intolerance. I told you what is cold intolerance. He is not able to be in a cold atmosphere. He is very comfortable in warm atmosphere, but he is not comfortable in a cold atmosphere. This is because of two things. I told you the BMR is reduced. Why is the BMR reduced? I told you sodium potassium pump is not functioning properly. Second thing is thyroid hormones stimulate mitochondrial oxidative phosphorylation. So this oxidative phosphorylation happens in the mitochondria. This will help in the production of heat. When the thyroid hormone is less, for example, T3, T4 is less, this mitochondrial oxidative phosphorylation and uncoupling of protein does not happen properly and it is reduced, which causes a decrease in the heat production, which causes cold intolerance. That means because the body heat is not being produced, the patient will be having cold intolerance. So, two things you have to remember. One is there is a decrease in the BMR because the sodium potassium pump is not functioning properly. Second one is mitochondrial oxidative phosphorylation is not happening. That is why there is cold intolerance. Next. Then the last question is in hypothyroidism, there is reduced protein synthesis and turnover, accumulation of mucopolysaccharides and interstitial fluid, which causes puffiness. I told you puffiness of the eyes is also one of the signs which has been told in the case. So puffiness in the eyes, non-pitting edema in the feet, all these are because of the presence of mucopolysaccharides. Carbohydrate metabolism is decreased. This is one important thing which you have to remember. That is why many of the hypothyroid patients will become obese and they will develop insulin tolerance. They will be developing insulin tolerance because they become obese. Glycogen synthesis exceeds breakdown. That means glycogen is stored more than it is broken down. So the glycogen storage increases. Lower BMR and lysis, which causes weight gain despite overappetite. So by this answers to all the 5 questions, you will be able to understand what are the causes of the signs and symptoms. So first one, myxedema. I told you there is a puffiness of the face, there is a puffiness of the legs. This is not because of accumulation of fluid, but it is because of the accumulation of mucopolysaccharides. So this edema is called non-pitting edema. It is not pitting edema. It is non-pitting edema. Cold intolerance is because of there is a decrease in the sodium potassium pump action and there is a decrease in the oxidation in the mitochondria. So both will cause a decrease in the heat production, which causes cold intolerance. Then glycogen storage will increase. Then bradycardia. Why is there bradycardia? Because the number of beta 1 adrenergic receptors are decreased and they become less sensitive to the action of thyroid hormone. So these basic things I told you are the causes of hypothyroidism. I told you this disease is called Hashimoto's disease. The common disease which causes hypothyroidism, which is very, very common nowadays, is Hashimoto's disease, where you have to see the TPO levels, thyroxine peroxidase, tyrosine peroxidase levels in the blood to make out whether the destruction of the cells is happening or not. So this completes hypothyroidism. Next question. Next case.
There is the slide change.
Yeah, it has changed. Now we have come to the next case. Here also it's a 28-year-old woman presents to the clinic with complaints of palpitations, weight loss, despite increased appetite. Here the patient is having an increased appetite but is not gaining in weight. In the previous case, I told you there is an increase in the weight in spite of decreased appetite. Here it's the reverse. The weight loss despite an increased appetite. That means the patient is eating voraciously but is not gaining weight but losing weight. Excessive sweating and heat intolerance for the past 3 months. So, in the previous case, it was cold intolerance. In this case, it is heat intolerance. And there is excessive sweating. She also reports anxiety, tremors, and difficulty in sleeping. Tremors means involuntary movements of the fingers. It is called tremors. Involuntary movement is called tremors. On examination, the pulse rate is 110 beats per minute. So the patient is tachycardic. In the previous case, it was bradycardia. Here it is tachycardia. But it is regular. Blood pressure is 130 by 70 millimeters of mercury. So the diastolic pressure is a little less and the systolic pressure is a little more. 130 by 70 millimeters of mercury. Ajay, the PPT is not to be seen. So remember, this is a case of hyperthyroidism. I think you were able to make out. This is a case of
Sir, is
hyperthyroidism.
it visible? Sir, is it
Yeah,
visible?
now it's visible.
Yes, sir.
The skin is warm and moist. Hands are having fine tremors. Eyes mild lid retraction and infrequent blinking. Neck is diffusely enlarged, non-tender thyroid gland. Investigations will show increase in the T3, increase in the T4, decrease in the serum TSH. Basal metabolic rate is markedly elevated. So when you look at this case, what is palpitation? The common confusion that the student has is between palpitations and palpation. I see this in the exam also. Many of the students are getting confused with palpitations and palpation. See, palpitation means an awareness of the heartbeat. See, normally when we are sitting, we are not aware of our heartbeat. But suppose we run or we have a tachycardia, we are aware of our heartbeat. That is called palpitations. So here, though the patient is sitting in the clinic, she is complaining of palpitations, weight loss despite increased appetite. She's eating well, but there is a weight loss, excessive sweating, and heat intolerance. She also reports anxiety and all this. Blood pressure, you remember, the diastolic is less and the systolic is slightly more. Yeah. Okay. Neck is diffusely enlarged. See, whenever there is an enlargement of the thyroid gland, it is called goiter. So, goiter can be euthyroid, hyperthyroid, or hypothyroid. That means when a person is having a goiter, goiter, it is only an enlargement of the thyroid gland. That does not mean that the patient is always having hyperthyroidism. Remember that. Though he is having a goiter, that could be because of increase in the thyroid or a decrease in the thyroid hormone, or it could be euthyroid. So if it is a normal thyroid levels, that is called euthyroid goiter. If there is an increase in the thyroid hormones and there is a goiter, that is called hyperthyroid goiter. If there is a decrease in the thyroid hormones and there is a goiter, that is called hypothyroid goiter. So here it is a hyperthyroid goiter because T3 and T4 are increased. Next slide. Which physiological feedback mechanism explains the low TSH despite high thyroid hormones levels? That means the thyroid hormones are more, but why is there a and there is a low TSH level? TSH level is low and high thyroid hormone levels. In the previous also I explained why TSH is high and the thyroid hormones are low. Negative feedback. List three metabolic effects of increased T3 T4 on carbohydrate, protein, and fat metabolism. So such type of questions will be having 3 marks. Understood? So list three metabolic effects of increased T3 T4 on carbohydrate, protein, and fat metabolism. Next slide. So you can see here the eyes. This is called exophthalmos. So exophthalmos is a very clear indication of hyperthyroidism. Okay, next slide. Yeah. Explain why the patient has an elevated basal metabolic rate. I think you'll be able to explain now very easily because in the previous I told you why he's having a low basal metabolic rate. How do thyroid hormones increase heart rate and cardiac output? I think you'll be able to tell this also because last time I told you what is the cause of the decrease in the heart rate and decrease in rate as well as cardiac output. Describe the role of hypothalamic pituitary thyroid axis in maintaining normal thyroid function. So this will be 1 mark, whereas that one question will be 3 marks. Next question. Next slide. So I told you it's a negative feedback. See, homeostasis is also an important question for you. Generally, they will be asking about positive feedback because most of the feedback mechanisms in the body are negative feedback. There are only a very few feedback which are positive. So physiologically, one positive feedback you can say is about normal delivery, understood, or a milk ejection reflex. All these are physiological positive feedbacks. But otherwise, it is mostly negative feedback. That means once the T3 T4 will increase, automatically the stimulating hormone will decrease. So negative feedback on the hypothalamic pituitary axis. High T3 and T4 inhibit the release of thyrotropin release and thyroid stimulating hormone from the anterior pituitary. Okay, next. Next slide. So carbohydrates. Remember, here there is an increase in the glucose. Remember, if there is only an increase in the glucose, don't write diabetes mellitus. There are many diabetogenic hormones. So when you are looking at the question, you have to look at all the data which is given to you. In the same way, when you come across a patient also, you have to look at only one investigation and put a diagnosis. You never do that because you have to look at the whole picture. Here, there is an increase in the glucose absorption in the gut, there is an increase in gluconeogenesis, there is an increase in the glycogenolysis. All this will cause hyperglycemia. Understood? All this will be causing hyperglycemia. What are all they? Increase in the glucose absorption from the gut, gluconeogenesis, glycogenolysis, hyperglycemia will be caused by all this. Proteins. Protein synthesis at normal levels is the function of thyroid hormone. Understood? When the thyroid hormone is at the normal level, there is a normal protein synthesis. There is an increase. That's why it is called an anabolic hormone. Understood? It is called a anabolic hormone at normal levels. But here it is a case of hyperthyroidism. That means there is an excess of thyroid hormone. When there is an excess of thyroid hormone, it causes protein catabolism. So this is one very special function of thyroid hormone. At normal levels, it is anabolic. At very high levels, it is catabolic. So that's why it causes muscle wasting. The person becomes very, very thin. Then on the fat metabolism, it causes lipolysis. That means the fat is broken down. There is an increase in the free fatty acids in the plasma and there is a decrease in the cholesterol levels. So that is why in hyperthyroidism, the patient becomes thin. One is there is a catabolism of the proteins, and the second one is there is an increase in the breakdown of fat. So that's why the patient becomes thin. Though he is having a very good appetite, he is very, very thin. Next question. Next one. Next slide.
Sir, is this slide change? Sir,
Yeah. Explain why the patient has an elevated basal metabolic rate. I told you in the previous thing why he has is having less
sir, are you there?
Hello? Okay. Sorry for the interruption. Some technical glitch. Am I audible now?
Yes, sir.
Yes, sir.
Okay. Okay. Go to the next one then. So we completed hyperthyroidism and hypothyroidism. So you have to be thorough with the functions of thyroid hormone regarding the basal metabolic rate, regarding its action. One more thing we talked about was about constipation in hypothyroidism, because this is also important. Thyroid hormone is responsible for the movement of the intestines also. So in hyperthyroidism, the person will be having diarrhea, whereas in hypothyroidism, the person will be having constipation. That means he will not be able to pass his motion frequently in hypothyroidism. Whereas here, because his motility will be high, the patient will be having diarrhea. This is also one reason why he will become thin. So the person with hyperthyroidism becomes thin because of three reasons. One is there is an increase in the basal metabolic rate, there is an increase in the destruction of proteins as well as destruction of fats, lipolysis, proteolysis. I told you to remember, normal levels of thyroid hormone causes anabolism, whereas increased level of thyroid hormone causes catabolism. That means there is a breakdown of proteins. And the last reason why he becomes thin is there is diarrhea. So all this will be causing the person to become thin. Yeah, next one. Next question. Next slide. You can go to the next slide. So we come to the third case. This is not very common nowadays. Previously, when we were students, it was common, but this is being asked in the exam. A 25-year-old woman from a rural area presents to the outpatient clinic with a visible swelling in front of her neck. I told you, what is the swelling in front of the neck called? Very good. It is called goiter. The swelling of the thyroid, because the thyroid is present near the front of the neck, that is called goiter, has gradually increased in size over the past year. She complains of a sense of fullness in the neck, but there is no pain. Remember, it is a painless swelling in front of the neck. The thyroid swelling will be a painless swelling in front of the neck, which moves with deglutition. This is a very important finding of the thyroid enlargement. When you swallow, the movement of the lower parts of the neck will be causing it to move up and down. So whenever you are seeing a swelling of the thyroid gland, ask the patient to swallow. Ask him to look up and swallow. If it moves with the deglutition, then it is a thyroid gland. Otherwise, it could be something else. There is no history of palpitations, weight loss, heat intolerance, constipation, or lethargy. See, I told you, palpitations are because of what? Because of the increased sensitivity of the beta adrenergic receptors as well as increase in the number. So in hyperthyroidism, you have palpitation, but this patient is not having palpitations. He is not having weight loss. I told you, if there is an increase in thyroid hormone, there will be weight loss. He is not having heat intolerance. She is not having heat intolerance. Heat intolerance is because of increase in the sodium potassium pump activity. He is not having constipation or lethargy, which is hypothyroidism. I told you, whenever there is a swelling of the neck, it could be euthyroid, hypothyroid, or hyperthyroid. So there is no history of both. She lives in an area known for iodine deficient soil and has no history of thyroid medication use. So she is in an area of iodine deficient soil. Previously, all the hilly areas used to be iodine deficient. The soil used to be iodine deficient. That's why these people used to have this type of goiter. On examination, in the neck, there is a diffuse, non-tender, smooth enlargement of the thyroid gland moving with swallowing. Pulse 78 per minute, which is normal. BP 110/70 millimeters of mercury, temperature 98.6 degrees Fahrenheit. No tremors, no attacks of thermos, skin and hair are normal, neurological examination is normal. Investigations: serum T3 normal, serum T4 normal, serum TSH slightly elevated, urinary iodine excretion is low. Anyone can tell what this is? A 25-year-old woman from a rural area presents to the outpatient clinic with a visible swelling in front of her neck. Anyone? Very good. Excellent. So here it is because of the iodine deficiency that the patient is having goiter. So that is called simple goiter. Simple goiter is because of the deficiency of iodine. In the exam, many of you are writing treatment of hypothyroidism is by giving iodine. That is wrong. Remember, iodine is not given for hypothyroid patient. Iodine is given only for patients who are having goiter because of the absence of iodine. Because nowadays the iodine is being given in salt. So most of the people are not having simple goiter. So don't write treatment of hypothyroidism is giving iodine. Treatment of hypothyroidism is giving thyroid hormone. Understood? They are given 25 micrograms or 100 micrograms of thyroid hormone. Thyroxine. It's called thyroxine. So that is the treatment. Don't write thyroid hormone is, I mean, iodine is the treatment for hypothyroidism. Okay. In the previous case of hyperthyroidism, I told you there is an increase in the systolic and there was a decrease in the diastolic. Why? Because I told you that the heat is increased in hyperthyroidism. When there is an increase in the heat, there is a vasodilatation. So when there is a vasodilatation, diastolic blood pressure will decrease. So remember, in hyperthyroidism, because of the vasodilatation, there is a decrease in the diastolic pressure. Why is there an increase in the systolic pressure? Because of the increased cardiac output as well as increase in the heart rate. There is an increase in the systolic pressure. So that's why in the previous slide, previous case, the patient was having a blood pressure of 130/70. Here it is normal. Next, temperature is also normal. Next slide. So you can see here, this is a simple goiter. There is a swelling which is very, very big and it is in front of the neck. It moves with the neck swallowing. It moves with the swallowing. It goes up and down with swallowing. So when you see such a diffuse swelling in front of the neck, it is mostly because of simple goiter. So questions that will be asked is describe the feedback mechanism regulating thyroid hormone. Same thing. I told you negative feedback mechanism. Explain the physiological role of iodine in thyroid hormone synthesis. So that's why I told you the synthesis of thyroid hormone is very important. All that iodine trapping, all that is coupling, all that is important. You have to be thorough with the 5 processes. Next. Next week. Differentiate between thyroid function status in simple goiter and toxic goiter. Toxic goiter is hyperthyroidism. I told you when there is hyperthyroidism also there could be a goiter. So that is called a toxic goiter. So difference between a simple goiter and a toxic goiter. How does TH stimulate thyroid gland growth? So whenever TSH is there, it also causes an increase in the swelling of the thyroid gland. Predict what would happen to TSH, T3, and T4 levels if iodine deficiency persists for several years without correction. So what will happen if it is going to continue like this? Next question. See, mostly the patients who are having simple goiter, except for the swelling, they will not be having any other problem. So as long as the swelling is there, they don't come to the doctor. But when it is causes pressure symptoms or when it becomes too big, then they come to the doctor. That's why these people used to come late in those days. So next case is a 4-month-old infant is brought to the pediatric clinic for poor feeding. constipation, and sluggish behavior. So, 4-month-old infant. The mother reports that the baby has been unusually quiet since birth and rarely correct. That means the baby is not active, it is sluggish. On examination, the child has coarse facial features, a large protruding tongue, dry skin, hypotonia, and an umbilical hernia. Growth parameters are below the 5th percentile for age. TSH is 120 microinternational units per liter. Free T4 is zero point 0.3 nanograms per DL. Total T4 is 2. So, free T4 and total T4 is less. TSH is high. Anyone would like to tell what this could be? A 4-month-old infant. Excellent, excellent. Yes, it is cretinism. So remember, sometimes they are asking cretinism. Cretinism means hypothyroidism in an infant. So why does this happen? Because sometimes the mother will be hypothyroid and the newborn may become hypothyroid. Understood? The mother is hypothyroid and the newborn may become hypothyroid. That's why now it is mandatory for the mother along with her iron to also check for thyroid. So this is very important. So the first blood test which are done to a mother is one is for anemia and the second one is for sugar, third one is for thyroid. So all the three tests are done in the first trimester. Because today some of you are not only from physiology, you are also joined from other years, second year, third year, you have joined. That's why this is important for you to understand. And growth parameters is also an important question for you in pediatrics. So you should know what is the 5th percentile, what is 6th percentile, what are all the growth parameters which happen in an infant. That's also important. And next one, next slide. Yeah. So you can see here there is an umbilical hernia. The baby is a little obese. It is looking stout. You can see here the tongue is protruding. I told the child was having high. So this is a typical case of a cretin. Understood? So that is the umbilical hernia. That is the puffiness of the face. That is the protruding tongue. Okay. Yeah. Next slide. Next question. Explain why TSH is elevated despite low thyroid hormone levels. Okay, next one. So you can see here protruding tongue, growth retardation with short limbs, coarse dry skin, lack of hair and teeth, mental deficiency, pot belly. Pot belly means the belly looks a little big like a pot. That's why it's called a pot belly. The previous slide showed you an umbilical hernia. Here it is a pot belly. That means the hernia is not there, but there is a pot belly. Sometimes an umbilical hernia will be present. Next. Yeah. What is the physiological role of thyroid hormone in brain development during infancy? This is very, very important because most of the cretins are, not most, all the cretins are idiotic. That means they have mental retardation. That's why that was called an idiotic phasis. In the previous slide was called, was having a idiotic phasis. So you should know what is the role of thyroid hormones in brain development. Does the untreated cretinism cause irreversible intellectual disability if therapy is delayed? That's why in every hypothyroid, whenever an infant is born, that has to be tested for thyroid hypothyroidism. So you have to test the thyroid hormone to every child for a mother who is on thyroid treatment or hypothyroid. If the child were treated immediately after birth, how would the negative feedback mechanism normalize T3 and T4? Next. So, congenital hypothyroidism, failure of the thyroid gland to produce adequate thyroid hormones. This could be number one because the mother is having a thyroid decrease, or it could be because the newborn is having a thyroid dysgenesis. That means the thyroid is not being produced in the newborn because of various reasons. So it could be a congenital hypothyroidism, or uh, generally it is because of congenital hypothyroidism. Sometimes it is because of the hypothyroidism in the mother. Second, why is there an increase in the TSH? I told you because there is a loss of the negative feedback. That means though the person is having hypothyroidism, that is thyroid hormone is low, the TSH is being stimulated more because the TRH is being stimulated. Then the brain development role, thyroid hormones produced neuronal differentiation. See, there are different types of neurons in the brain, and there are different types of neuroglia. So these neuroglia and neurons are differentiated by the thyroid hormones. But more important than that is synaptogenesis. New synapses are formed in the brain because of thyroid hormone. Whenever there is a decrease in the thyroid hormone, these synapses are not formed. And the third important function of thyroid hormone is myelination in the developing brain. So in the brain, the myelin sheath is formed. The myelination happens because of thyroid hormone. So whenever the thyroid hormone is decreased, myelination is decreased, synapses are decreased, and the neuronal differentiation is decreased. That's why the patient will become mentally retarded. That is why it is very, very important to give the treatment very, very early in life. Irreversible disability. Otherwise, there is a irreversible disability which is because of the decrease in the thyroid hormone. Last one is you have to give thyroxine, which increases the thyroid hormones, which resolves the negative feedback. TRS and TSH levels become normal. So with this, we conclude today's session with the discussion of thyroid hormone. Number one was hypothyroidism in an adult, which is called myxedema. Why it is called myxedema, I told you. It is because of the presence of the non-pitting edema, which is called myxedema, where the patient is obese, he is cold intolerant, and all that. So, any doubts regarding this, you can just go back to your textbook and read the functions of thyroid hormone, because thyroid is given many number of times. Thyroid and Cushing syndrome have been given the highest number of times. Whether it is hypothyroidism, hyperthyroidism, or Cushing syndrome, these three have been given the highest number of times. Whereas acromegaly and diabetes mellitus, diabetes insipidus have been given, but not as many times as Cushing syndrome and hyper or hypothyroidism. Only thing is, be careful when you are writing about goiter. Don't think that goiter is always because of hypo or hyperthyroidism. It could be also because of euthyroidism. That means the thyroid hormones could be normal. Only then you will be having to give iodine if it is a simple goiter. If it is a goiter because of hyperthyroidism, you have to treat the hyper. The common cause of hyperthyroidism, which causes the goiter, is called Graves' disease. Graves, Graves' disease. Here, what happens? The antibodies which are produced are similar to the thyroid stimulating hormone. So these antibodies go and stimulate the thyroid hormone to produce more and more hormones. So that is why the patient becomes hyperthyroid. So that is called Graves' disease. Whereas hypothyroidism, the disease is called Hashimoto's disease. In hypothyroidism, it is called Hashimoto's disease. In hyperthyroidism, it is called Graves' disease. And if the goiter is because of iodine deficiency, it is called simple goiter. And if the hypothyroidism is because is present in infants or newborns, then it is called cretinism. Understood? So with this, I would like to conclude today's session. Thank you very much for your patient hearing. I am very sorry about the glitch which we had, but thank you, Ajay, for correcting the glitch very easily. So looking forward to tomorrow's class. You can give a feedback to me about how the class was, whether you want a change in the way it is being told, because all of you have thoroughly completed your revision. That's what I feel. So this is only to brush up the clinical cases that I'm taking. I'm not going to details about the functions of thyroid hormone and all that. So
Yes, sir. Can we conclude the session, sir?
yeah, we can conclude. Thank you.
Yes, sir. On behalf
Tomorrow's
of
will,
yes, yes, sir.
tomorrow's will be another endocrine class.
Yes,
Okay.
sir. Yes, on behalf of JSL Medical College Rajahmundry and National Medicos Organization, we sincerely thank all participants for joining day one of the physiology clinical cases discussion. And also a special note of gratitude to Dr. Srinivasa, sir, Professor Department of Physiology, JSL Medical College, Rajahmundry, for his insightful and engaging session on introduction to clinical cases and case discussion on the thyroid gland. We appreciate your active participation and look forward to your presence in your upcoming sessions. Thank you. And my special
Thank you.
thanks to Dr. Swastika, Clirnet team, and Ritu. Thank you. Thank you, sir.
Yeah, thank you.
Sir, can we end up the session?
Yeah, we'll end up. Thank you. Thank
Yes.
you so much.
Thank you, sir. Thank you. Swastika, hello. Hello. Swastika, am I audible?
Hello.
Swastika, am I audible? Hello. Hello.
Hello.
Hello, Swastika, am I audible?
Sir.
Hello.
Hello.
Yes, Swastika, am I audible?
Yes, yes, you're audible, sir.
Yes, we can end up the session. The session is
Okay.
over.
So should I conclude the session?
Yes, we can conclude the session.
Okay. So, thank you so much to all the dignitaries present here for joining with us today. Thank you so much, sir, for. Hello, am I audible to you now?
Yes, Swastika, you are audible.
Okay.
Yes.
So, thank you so much for all the dignitaries present here. Clirnet is really glad to have all these brilliant people together in this session today. And I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much to everyone.
Thank you, Swastika.
Thank you. Have a good day.